Good afternoon. My name is Krishna Singh. I'd like to introduce expert panelists that are going to review with us today 2 cases from Asan Medical Center. My co-moderator, Dr. Choi, will be evaluating the cases along with our panelists. I don't know if we're all set to go to Asan Medical Center? Okay, very good. Take it away. Good afternoon. It's Krishna Singh, Dr. Choi, and a fairly robust panel of experts waiting for you to introduce your case. Could you introduce your case for us, please?
Oh, this is me?
Yeah.
Okay. I did not notice that. I'm sorry about that. I'm Dr. Urasawa from Sapporo, Japan, and today's case is critical limb ischemia, Rutherford 5, a very small unhealing ulcer at the fourth toe. So, can I have the case presentation?
Yeah. The patient is 63 years old man, and he presented with diabetic foot pain. The first toe is gangrenous change, and the ABI was 0.68 on right side, and he had a long-standing history of diabetes and hypertension, and he also had chronic kidney disease, and he performed on hemodialysis. Next, please. Yeah. 2 years ago, he performed amputation of left 4 and 5 toes. Next. The echocardiography was normal ejection fraction. Next. Yeah.
Okay, this is the case. So, left side has a much bigger ulcer, and the patient cannot wait the treatment on this right coach. So the wrist side foot was already treated previously. So today's target is right side BK artery, and also this side is Rutherford 5 CLI foot. So today's, I take up ipsilateral antegrade puncture, right common femoral artery, and I already inserted 4.5 French sheathless guiding catheter to the pop. And I started the guide wire maneuver for the ATA. So can I have the first picture today? Yeah. Can I see the picture? Yeah, there is a very diseased ATA and occluded peroneal arteries and also occluded posterior arteries. As you can see, there is some nice small channel or connection at the ATA mid part, and finally you can see the dorsalis pedis. But the problem is you cannot see any sign or open segment of posterior artery. This patient has an unhealing ulcer on the fourth toe, so that means the target artery should be posterior artery in this case. But I think as the PTA is quite difficult to recognize in this case. So my first approach is cross the guide wire to the ATA and dilate them and look at the angiogram, what's happened after that.
Okay, Dr.
Is there any comment? Yes.
This is Dr. Choi.
Hi.
I cannot see clearly the classification, but the patient history is CKD with hemodialysis and long-standing diabetes. So, how about the classification at the target artery?
Yeah, as you said, the classification is not severe in this case. There is some classification, but not severe. So can I have the next picture, please? Yeah, I took a DSA as the proximal portion of ATA, like this. So you can see some peroneal flow by collateral circulation. Can I have the next one, please? This is mid part of the BK artery. Next one, please. The patient moving. So it's not a good picture, but anyway, ATA has just stenosis, not occlusion. So the first step I have to do is fix the stenotic lesion on the ATA by angioplasty, and to see what I can do after that. So what do you think? Is there any comment for this?
Yeah, I think it's reasonable because the peroneal and the posterior tibial artery, we cannot see the clear distal collateral, so I think our target is ATA.
Wow, where is the proximal mark of the bone?
We have many panelists, so I will ask the panelists to their strategy.
There is no.
Dr.
Yeah, could you dilate that?
What do you think
1,
about
2,
the
3.
target?
1, 2, 3. 4. This time, yeah.
Yeah, I think, Dr. Choi, I think Dr. Urasawa has got a right strategy to treat the anterior tibial artery first, and then have a good view of what's going on in the foot and see if we should persist and open up the dorsalis pedis if you can, because it does look like the dorsalis pedis is occluded.
Yeah, one would think that if you just get the AT open, you're going to at least salvage the majority of the limb, right? You could lose the toes, and at least that'll give you an option to come retrograde if the posterior tibia is still your target at some point.
4, 5, 6.
I would tend to think that just
7,
from the
8,
angio, that
9, 10.
I see diffuse calcification throughout these arteries. So I think that this is a fairly heavily calcified artery in the
DA,
PT
please,
and
DA,
in the perineal.
DA. Normal. DA. Okay? Okay? Are you ready? Okay. Okay.
Dr. Urasawa, can I just ask you, what is your strategy for long tibial lesions? Do you prefer a more short focal balloon to get more strength, or do you believe in a more tapered long balloon? What is your...
Basically, I always use long balloon for tibial artery. And also I use a non-tapered balloon. The reason is, the tibial artery is just a duct. There is no side branch at all, usually. So that means the distal part of tibial artery and the proximal part has the same diameter. You don't need a tapered balloon. But in the case of peroneal artery, it's a tapered artery, so you need a tapered balloon for peroneal artery dilatation.
Anybody has any opinion on whether there's actually evidence and the need for a tapered balloon, or go straight for 2.5 or 3 by 200?
So proximal to the distal. Yeah, proximal to the distal.
I don't know that there's any data to support it, but the challenge I have with tapered balloons or long balloons is it's usually a better final balloon. I like dilating up the principal arteries, focal areas, to crack it. Then I think those compliant or semi-compliant balloons tend to dilate nicely and give you a lot of usefulness. I like the tapered balloons. I think they're actually quite good.
Where's the guide wire? Over there, yeah.
Actually, for me, the last couple of months I've moved towards a more non-compliant balloon, about 120 length from Obersnitch, that really does a lot of high-pressure balloon dilatation to crack that calcium. And then because I don't want to hang around too long doing multiple balloon inflations, I top it off with a long balloon and go for tea or something like that after that.
The other thing we have to think about is if you use the short balloon in a long CTO lesion, every time you dilate the balloon, you have a crack and an atherosclerotic plaque as the shoulder of the balloon. So that's the major reason we have to use the long balloon for long, big CTO. No, not good. There you go. You have to, can I have the inflator? Just a little bit. Yep, okay. 20. I'll try 20. 20. There you go. So, can I have a 2.5 millimeter button? Sure. So, when I'm look at the angiogram after 2 millimeter balloon dilatation, the proximal part is a little bit larger than 2 millimeter. So I decided to use 2.5 millimeter wrong balloon. There you go. It's okay, it's okay. Proximal part. Okay, let's try. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 12. Can I have a DSM mode? DSM mode. 14 atmosphere. 14. 14? Yeah. You know, in the case of calcified vision, it's sometimes quite difficult to see the fully expansion of the balloon because of the calcium, you know, or interference of the calcium shadow and the balloon contrast medium. In such case, it's quite useful to use the DSA mode to see the full expansion of the balloon. And let me show you the secret. Okay. I said, go. Yeah, you should deflate the balloon quickly, okay? Go. So it's fully expanded. So can I have the cine mode, please? DA mode, cine mode. Coronary mode, please.
Lawrence, in cases like that, would you consider atherectomy for these kind of cases in the U.S.? Or?
So I was going to ask Sensei,
this.
you know, there's this interest in the U.S. about this kind of plaque remodeling.
Looks better.
For the below-the-knee stuff,
a
lot of people are trying to plaque modify the calcium. There's several ways to do it. There's rotational devices, there's orbital devices, there's frankly directional atherectomy as well. But I think I don't know that there's a strong data set that says you have to. But I think a lot of people in theory believe that if you change the arterial compliance in the infrapopliteal segment, you get a better, not so much patency, better angiographic upfront appearance with your balloons. It'd be very interesting to see that combination with DCBs, if it ever comes to that, as to whether or not it's useful. But I think a lot of folks in the U.S. would try to plaque modify this calcific disease with probably orbital or a rotational device of some form.
Okay. Yeah, cranial. Okay. There you go. Pose 2. I want to see the toe. DSA, please. Okay. Don't move, please.
움직이지 마세요. 잠깐만 움직이지 마세요.
There is wind brushing. Well, can I have the previous picture? So I used 2 millimeter long balloon and a 2.5 millimeter long balloon for proximal half, and result is like this. The flow is much better than before. And next one, please. And actually, you can see the wound blushing on the pose 2 by this DSA. Tip of the pose 2 was stained. So that means I think this angioplasty is good enough for this case. So we should stop this intervention at this point. What do you think?
Yeah, there's just 2 places of dissection. There's one proximal, one in the mid-segment.
Yes.
So would you just tack those up a little bit more with balloon? But
sure.
If you have maintained flow, I think that's a reasonable stopping point.
Yeah, I'd like to try a 2 millimeter balloon for distal again, maybe 2 or 3 minutes, long inflation. And I think that's fixed the problem, I guess. Yep, let's try. 2 millimeter balloon again for distal.
옆방으로 갈까요? 네네네. 오케이. 네. Yeah. Okay, Dr. Urasawa.
Yes.
We will move to next, so we will come back again. Is
Okay,
okay?
thank you. Thank you very much.
Okay. Yeah.
Good afternoon. Okay. Yes,
Hello.
you introduce yourself.
Hi, hey, can you hear us?
Yep.
Okay, good evening. This is Dr. Sucha here. I'm here with Dr. Park at Asan Medical Center. Dr. Park's going to introduce the case.
Yes, I'm Dr. Park and Dr. Bae in Asan Medical Center Fellow. And I will present our case. A 74 years old male patient admitted for measurement of wound of right toe with claudication. 5 years ago, he underwent successful PTA at both SFA and right popliteal artery. The lower extremity CT angiogram showed severe stenosis at right SFA and total occlusion of right popliteal artery and both ATA. He has a history of hypertension, diabetes, and hyperlipidemia. So he has wound in right toe, so we approached antegrade.
Great, so right lower extremity, critical limb ischemia with ulcers in the right foot, a history of revascularization in the past, now with a CT angio showing a high-grade right SFA, stenosis, and right popliteal occlusion. Dr. Park's gotten access via the antegrade approach in the right leg. And can you see the angiographic image right now?
We can.
Okay, great. So I'm going to go ahead and play this. This was the first image. And you can see there a high-grade stenosis in the proximal right SFA. And then an occlusion in the P2 segment with reconstitution there. You can faintly see it over here of the posterior tibial artery and the perineal artery, which was more apparent by the CT angiogram. So move to the next image here. Here's the proximal right SFA. So I'll stop here for a moment and ask the moderators on the panel, how would you treat this stenosis?
Robbie, was this a site that was previously treated? Is this the same site or is this a different site? Do you know?
Yeah, I don't know. I know it's been a right SFA and right popliteal angioplasty, POBA only in the past. Unclear if this was the site of the right SFA.
Okay. I mean, it seems focal enough that a simple balloon would work. I don't know that you need to do anything else special to it, but I'll defer to the rest of my colleagues.
I think what I would do with this would be predicated on what the angiogram showed distally. This is a patient with CLI, obviously, and I would have probably given the most durable result. This is an inflow lesion that may impact on runoff and what you do with the runoff. So, Ravi, I wouldn't be able to answer your question because I haven't seen the runoff and what you plan to do with the runoff. But to Lawrence's point, maybe less is more, balloon angioplasty here, but I suspect even with this, Lawrence, you'd probably come back, don't you think? Even though it's a small, short lesion.
It might.
I'm
So
surprised
balloon
you didn't say
angioplasty,
atherectomy.
POBA or DCB?
Yeah, I guess the question is, what do you lose on this? I think that to Chris's point, I think that if you just do a balloon and see what it looks like, I don't know that you gain a lot with the DCB for this short a segment, but I think it wouldn't hurt. I just don't think that it will clearly make a big difference for you.
Okay, great. Anybody advocate for atherectomy here or stent here? Okay. Well, so I'm...
Dr. Choi.
Go ahead.
Yeah. I think that this patient is a critical limb ischemia patient, so I'd like to more focus on the PTK intervention. So I want to usually simple balloon angioplasty without stent or something.
Okay. Great. So I'll move on here. What we did here was we did an angioplasty first. This is a 5.0 by 40 Admiral. And then we followed that. Here's the result after angioplasty alone. But because he's had restenosis after angioplasty in the past, we elected to move forward with DCB here, just to get a more durable result, even though it is a short lesion. And here is a 5.0 by 60 impact Admiral, inflated to 12 atmospheres. We left this up for 3 minutes, right there. And here's a result after that. So there's a small linear, non-flow limiting dissection. Would anybody want to do anything more here?
I think I would probably leave this alone, Ravi, and I want to see really what the main course is down below the knee, and what you plan to intend to do with that.
So then we advanced there's a 655 Ansel. We advanced that down to the P1 segment of the popliteal artery and took our first image there. And this is what we've got. Okay, so
Why Anjo is upside down in Korea?
yeah, it is upside down. I'm not sure if is there a way to turn that around?
For integrated approach,
We didn't want things to be too easy for you.
it's more comfortable.
So
You can see the reconstitution right there.
Without knowing the upstream, but this is likely the downstream restenosis, and this was angioplasty alone?
This was angioplasty alone 5 years ago. So by CT angiogram, we've got good two-vessel runoff, the perineal going down to the ankle and the posterior tibial going into the foot. So we haven't taken an image here, but we've got CTA imaging showing that below this it looks pretty good. So we've got this area here. You can see it's very well collateralized. There appears to be a path through here. And so we tried to get through that.
Maybe not, because CT.
Yeah. And somebody said maybe not, and I think you're correct. These are microchannels. There is a path most of the way through, but right before the reconstitution, we're having a hard time getting back in. I'd initially opened up a Stato 30 wire expecting a CTO. So we started with that to try to get through, but right before the reconstitution point, we're having a hard time getting into the true lumen there. We have a CXI 018 catheter for support, and we have tried so far a glide wire M, that's an 018 Terumo wire, and we now are in with a Terumo run-through, but we may have to go to a CTO wire, and that's kind of where we are right now. So that's our final image, and you can see the reconstitution right there. And it is a total occlusion with microchannels about 2/3 of the way through the occlusion.
So the channel we saw was just a collateral channel, do you think?
I don't think it's collateral. It looks like it's a true channel most of the way through, but somewhere near before the reconstitution point, I think it's just a total occlusion with microchannels, so it appears like it's a true lumen, but it's not. I'm going to go ahead and take another picture here, and then we'll start trying to access again. If you can see there right before the wire tip, there's a CXI tip. So is that projecting well? You can see there's the appearance of a channel, and we're going to try to follow that.
So tell us a little bit about your technology you're using. You have a CXI backed up on what type of wire?
This right now is a run-through. This is a very simple wire, coronary, and we've tried a CTO wire and we've tried a glide wire. My concern was that if there are microchannels, I don't want to create a dissection, so I'm going to see where I can get with this and then switch out from there. But as you can see right there, it seems to go into a different trajectory right there. All right, so if I can stay a little bit more lateral here, I may be able to get in, but
I wonder if we're getting fooled in the AP view to where it is in space on the.
right,
If you went lateral, you probably see it separate to the other one. That might be entering at least something.
yeah, it's a little bit off, and we're in our second angle right now, but probably change it again in just a moment. So it goes very easily, but that's clearly not the right lumen.
So Lawrence, as you're working there, we don't want to interrupt your concentration. Lawrence, we're really struggling with re-entry devices below the knee. Obviously, sticking a large caliber device like the output could be problematic. Have you had any other experiences with the other evolving technologies? Have you used Wingman yet?
I have not. We have it available to us, but I have not. I've done outback to the tibial plateau, and I've seen some folks use it in retrograde pedal, which is kind of crazy. But the things like anterior, those types of things, if you're close, it allows you to get re-entry. But this is an unforgiving space like your coronaries. So anything small is probably the right answer. But I think, again, we're getting so facile now with retrograde pedal that's kind of where we go first rather than trying to re-enter.
Tell us a little bit about your pre-procedure planning here. When you see something like this, do you prep these for pedal access potentially, routinely?
Not routinely. Sometimes it's on the fly, but if it's going to be a challenge, if we didn't think there was a channel, then we generally do it up front.
So because I'm having a hard time getting through, I'm going to try a Fielder XT, see if I can get one of those microchannels into the true lumen. I've changed the angle a little bit, so let's see if this helps. Let me get that fork on here, please.
So, Dr. Yokoi, how would you look at something like this from technology
because
point of view?
injecting from proximal caster, popliteal artery, there are lots of collateral. So you have to select the caster in proximal to the occluded segment, and we use 1 cc microsyringe and inject these vessels, and we'll see probably it's dissected. And so we have to think about the timing to. Now he crossed, maybe not. And maybe we'll switch to the distal puncture, or it's about timing. But injecting from proximal big caster, looks like a mess, and I cannot identify the vessel well. So selective injection is much better to understand distal what's going on right now.
Yeah, I agree.
Absolutely, I completely agree with you.
The angio showed not clear connection between the proximal and distal, so maybe we cannot see clear the connection. So selective injection may help, and or distal puncture. So to try over why it does not go directly to the true lumen, it goes out the collateral or subintimal space. So, yeah.
Well, there's clearly a fenestration there.
Maybe the angled view is much easier to understand where's dissecting.
Yeah. I think a different angle here would be better, I agree. We've gone through a few angles already. We'll go a little bit steeper now.
Yeah, I think there's a small tributary to the medial side of that leg, which is where that wire's going. It's taking that collateral.
Maybe in this kind
And
of
I completely
case,
agree.
softer wire will
There we go.
fine. Like a regalia wire.
It's already a little, yeah.
So you can see there the multiple channels. That's the one we need to take. So I was hoping that we would get through very quickly, and that's why I didn't do a selective angio first, but you're absolutely right. This lays it out a lot better. I'm going to go in again with the Fielder XT. I can try Regalia
Maybe
next.
you better change the new wire for very slippery one. Same wire goes to the same place.
Yeah, fair enough. You're absolutely right. I'm going to try this one more time, and then we'll go in again. Oh, that's not it.
So, Dr. Yokoi, you just said same wire will go to the same place. Do you have a step methodology where you start with a specific wire, something like this, a lubricious wire, or maybe...
This one may have some channel. So, each wire has its own specific. So we change to the cruise wire. The cruise wire and.
So the cruise wire is named as a Regalia wire, right? Regalia wire.
Any wires you have in mind? But the thing is, this wire is migrated in a false place, and so with a bit of change.
So Lawrence, how do you gauge these things? You start with a 14 wire, you come up with an obstruction like this. Which way do you go? Do you ever? What drives you to an 018 wire like a V18, something along those lines, or sticking with an 010 system, an 014 system? Give us your algorithm for treating, going after a lesion like this.
Yeah, so our wire escalation is I'm pretty simple-minded. I start with, I like a lubricious wire for most of these things, so we start with a V14 type of wire, something with a lubricious tip. And then should that fail, we can try some of the CTO wires, things like a Victory wire up to a 30-gram tip. Or if you really want to escalate, if it's just that little bit of extra push that you need, either a coil tip Victory or the V18 with some support will get you across most of these distal caps. The challenge for me is not so much that you can't push, it's always been where you make your mistake early. And the challenge with that is, I think is illustrated here, is that the dissection plane generally then begets the dissection plane, right? So you end up going to the same location twice. And that's where I think this idea of retrograde access becomes more useful.
Or change the stiff wire at the moment.
Right. Yeah. I like that quote, by the way, from Sensei Yokoi about the same wire goes to the same place. I like that.
I think you make a very
seems to be
important
playing out
point.
very well here. So what I'm going in with now is a Terumo Glide Wire M. This is an 018 wire. It's really gotten me out of trouble a lot of times. The problem is it's not very radiopaque. So we may not be able to see it, which would be obviously problematic. I'm going to see if we can get in there. Do you have any experience with the Glide Wire M? It's kind of like the Advantage.
In the old coronary days, they used to make a Terumo Gold.
Yeah,
it had this
that's
little
right.
bulbous tip on the front end, and it used to follow a lumen pretty nicely. They stopped making that.
Can't see it. Yeah, this is very similar to that, and can make you look really good at times, but I'm not sure this is going to be one of those times. Okay. There it is, right there.
I'm sorry, I missed the initial presentation. Is this an antegrade stick?
This is an antegrade stick, that's right.
I think that's an important point to start with. Planning for success, obviously you lose a fair amount of torqueability coming from the contralateral, just complicates everything. And then to Lawrence's observation, your first pass is many times your marker of success or failure, or how long you're going to be in this procedure, particularly when you take a lubricious wire and it goes subintimally.
Yeah. Exactly. We're going to switch to a Regalia wire here, and then I think pretty soon after that we'll have to get pedal access because this is not going anywhere. Get 3cc syringe here. It was a little deceptive right from the start. So either was occluded right from the start, or my first pass went into the dissection plane, as we were just talking about, and then has resulted in a false passage every other time since then. Looks like it should be pretty straightforward, but it's not.
Yeah, I think three-dimensionally it's about, I don't know, probably 4 centimeters below the tibial plateau. There's that area that's double density, where you see the rest of that channel. It's either coming at you or away from you.
Yeah.
I think that's your collateral connection.
So, Lawrence, when do you start thinking about, where you say enough's enough, and then I'm going to bring this patient back, I've opened up an inflow lesion, I'm going to have some more distal perfusion, I like this to heal up, and bring them back. What's your algorithm on that? Understanding that you've sort of done a half job, if you will. How long do you wait, and how do you manage that situation?
I really wish I had a better sense of an answer for you. The concern I would have is if we got into something that ended up being more dissected than anything else. There you go. It was right at that double density, huh?
Worked out
So
well.
if you had a dissection, I
there
think
from the panel.
if it looks
Now,
like
here's
it's
the thing.
perforated.
I'm not sure if I'm in the PT or the perineal, so let's get a better picture of that, because we prefer to be in the PT, of course. All right, that's good.
I like that.
Oh, you have succeeded.
Did the wire take a branch off that PT downstream?
I think it's in the perineal and off a branch over there. Let me try to see if I can pull back.
Okay, Doctor, we will move to next room and we'll come back. It's okay. Dr. Urasawa already finished his case.
Okay, great.
Okay. 옆으로.
Okay.
옆으로 옮겨주세요.
Sensei.
Hi, I finished. So let me show you the picture. As Dr. Garcia pointed out, the good point, there is a small dissection at distal and the mid portion of ATA. So I used the 2 mm wrong balloon to fix the dissection plane. 2 minutes wrong inflation with a relatively low pressure, maybe 8 or atmosphere or something. So this is the proximal portion. I did the distal portion again, and this in the same way. And next one, please. Next one is the contrast DSA of last shot, the proximal part. There is no dissection at all. Next one, please. And the middle part of the ATA. Dissection well healed. Next one, please. Distal ATA. They're relatively clean. Okay. The next one is below the ankle area. You can see a very brisk flow, and also this patient was well preserved peroral arch he has. So that means this ATA is not target artery for his patient foot, but this is good enough because of the peroral arch was widely open, and Host 2 has a good blood supply by this intervention. So I think it's time to stop this procedure.
Very good job. Outstanding.
I have some question to Professor Cho. And I'm a vascular surgeon, and I want to make a discussion about the indication of PTA of a below the knee lesion. Does this patient present any symptom?
He has a small wound, non-healing ulcer.
No symptom?
Yeah, he has a symptom.
If the patient present no symptom with the same angiography, in that case, will you do something?
No.
For it?
No. Well, the clear indication of BK artery intervention is R5 and R6 patient. The problem is R4, Rutherford 4, resting pain. Ischemic resting pain is the most problematic situation because intervention, we can do anything, in that such kind of patient. But the problem is 2 months or 3 months later, everything come back. So the same symptom. So in the case of Rutherford 4 is the the biggest problem in many cases.
Dr. Urasawa,
yes,
just looking at the dorsalis pedis, it's a little bit hazy around the dorsalis pedis.
Yes.
And, it just doesn't look, well, you've done a great job of the rest of the artery, so you make the native artery look not so nice. So would you consider doing a short focal balloon over there, or you think you're going to leave it?
You're right. There is some minor stenosis at dorsalis pedis, but the stenosis degree of the stenosis is about 50%, or maybe 75% at most. If I touch here, maybe this region also re-stenos in the future.
Could you give us another projection on the lateral foot with the DSA?
Below the ankle area?
A different projection of the lateral foot?
Oh, okay, sure. Areo, please.
Yes.
Okay. DSA, please. Please don't move.
잠깐 움직이지 마세요.
So, do we have to fix that stenosis?
Let's ask the panel.
Maybe not.
Yeah. We can see calcification clearly, and also we didn't expect the abrupt closure, so I think it's enough to his symptom.
Yeah, so I think so too.
Supply.
So I'd like to finish my case.
Congratulations. Very
Thank you very much.
successful procedure.
Thank you. Thanks.
Ravi, we're back with you.
Okay, great. So we've got the wire down the posterior tibial, and we were trying to get well, before I say what we were trying to do, let me ask the panel, how should we treat this? So you've got this subtotal occlusion versus total occlusion. What would be some recommendations?
We don't have a sense as to when it failed. We just know it was treated 5 years ago. Is that right?
Hold wire. That's correct. Hold wire. Okay, that's good. That's correct. We don't know when the ulcer started.
I think in our practice, I think you have a couple options you can do.
Why not inject from here? We can see the plantar vessels and.
Yeah.
I tried to do that, but I'm not getting any flow back. Although I've got very good.
I see.
I've got very good movement of the wire, so I'm pretty sure I'm in trilumen, but just not enough flow in that area. So it's moving very easily.
Mm-hmm.
So what I was planning on doing here was doing atherectomy of that segment, followed by DCB for a more longer-lasting result. In order to do that, I want to, given critical ischemia, put an embolic protection device down, and that would not go through the total occlusion. So I need to balloon that total occlusion as a result, but we had a short wire, so I had to switch out for a long wire. We're not going in with the balloon. We're going in with the 2O balloon. 2O100, that's fine. And we're going to balloon that segment, create enough space for the embolic protection device, and then move forward. Would anybody just go ahead and treat that with a DCB or stent it?
I was going to say that I think you have a couple options. I think that you could do atherectomy DCB. It was 5 years between occlusions, and that may give you the bang for your buck that it'll heal. The alternative would be to go in with a stent approach, and for that location, the interwoven nitinol stent, such as a Supera, may be a good choice for that area. The problem is Supera has an OD that's it's non-tapered, and it's 4.5 at the smallest, and it's 6.5 at the biggest if you want to use one. And so going across the tibial plateau does become a little bit more challenging, but it's still a possibility, and it should eliminate the idea of fracture there. And the Leipzig data on the popliteal segment is actually quite good now at 4 years. So that would be another alternative.
Okay, all right, let's go here. Yes, the main reason I agree with you not to do that would be the size mismatch. Although we'll get a much better idea of what this looks like down after this balloon. Very well may be that the size mismatch is largely due to underfilling of the distal area. Okay.
Sorry, could we have a runoff? Could we have an angiogram of the runoff? Is that all right? Or have you done one already?
No, we have the CT angio guiding us, but I'll go ahead and do that right now.
Yep, thanks.
That doesn't look too good.
Balloon size is 2.0.
No, the 2.0, yeah. So the wire looks.
The 2.0 is a little bit smaller.
The wire is definitely in true lumen here. Let's see. Now, let me get that CXI again, please. I'm going to try to put it a little more proximally.
CXI? Yeah.
You know, somebody had mentioned earlier taking a picture selectively in the vessel, and that is always a good idea. It was just moving so freely that I didn't do that, and I hope I don't come to regret that decision. There's always a chance that even though it moves freely, you're in the subintimal space.
Yeah, I think there's a lot of recoil. I think your geography of the real estate that your wire's taken up in a subtotally occluded lesion is probably what's limiting your flow.
Hope that's all it is. Let's try this. Okay. Wire out, please.
Choi.
And 3 cc syringe again. All right, thank you.
Perhaps you can consider a double injection, one through the CXI and the other through the sheath.
Yeah, just to do it simultaneously. I agree, that would be a good idea. Let's see what I get back here. Yeah, you know, there's nothing here which is concerning because I'm quite proximal, and even if there is a total occlusion, there should be some flow. You know, that sinking feeling whenever you pull back from a catheter and see nothing there.
Yeah. One way to avoid that before you lose your position is put a TUI burst on that. Fill it with saline. That way it's
there we go. I'm getting some blood back now.
And then you just go ahead and inject from there. There's no air involved with that, and you don't have to lose your wire.
Yeah, I'm getting some blood back here, so we can take a picture here and see what's going on. All right, there we go. All right. That's definitely true lumen. So I'm not sure why it was so problematic earlier.
He is very cautious guy.
What does this say? They say the difference between they're doing the right thing and the wrong thing is 4 hours.
Yeah, I think the collateral vessel is relatively quite big, so 2 balloon is very small for this patient, so
yeah,
I recommend more bigger size.
Well, I think they're now at a crossroads, right? So the question is, do you stick with an atherectomy approach or just just stent it, right? So I think this is all inflow that's not allowing the outflow.
Yeah, I agree. I'm going to still try to do the atherectomy approach. And the purpose of the balloon was just to create enough space for the embolic protection device. Let's see if that goes through. Spider.
We'd like to know the information of the distal tibial vessels around here. If you have a chance to inject the dye from here, the proximal, and I would like to know the antitibial and posterior, the terminal portion of the peroneal arteries. So,
we'll do that in just a moment.
if you could, right now, unless we get the whole picture of the distal tibial arteries, we can't make a strategy for that. Now I understand that the
That's just filling backwards.
So
I think we should
can't
be okay
see
there.
the antitibial arteries very well.
The anteritibial artery is totally included.
Yeah. That's a nice picture.
Yeah. So there's got to be some multifocal issues in the posterior tibial, and then the outflow has disease as well.
Yeah, the outflow does. In the previous picture we saw, it looked pretty good. In the mid segment, I think it's just occluded proximally. But let's go ahead and get this in. You have the wire out? Okay, great. The other option, of course, is just to do a DCB alone, but I think we're going to end up with a lot of recoil and not a good long-term result for him.
Just looking at the CTA and an angio, there's quite a bit of calcium in the distal PT. And do you think this is going to impact the decision-making process for the DCB?
That's a good question. So is there a risk of using a DCB? As I went through just fine, I'm going to go ahead and get this wire out. Okay. Now I'm going to go ahead and use it regardless because I've got a filter down here. But I understand your concern using a drug-coated balloon with a potential theoretical higher risk of embolization in a patient with a critical limb ischemia. All right, so we hopefully can go in now with our Turbo Hawk.
Why is it prefer mono balloons, OTW, and injector dye, and keeping a wire, and mono, each time they have to remove the balloon systems and cannot inject the distal, we can't get the information of the distal vessels. So I prefer the OTWs, and wasting time for each time we have to remove the balloons, and I don't know why many physicians prefer the mono, but I like OTWs.
Just for support, you mean? That's a good point. It can minimize the number of steps. Okay. So this is a TurboHawk SXC. It's a small vessel cutter, calcium cutter, with a long nose cone. So the S stands for small vessel, X for long nose cone, and C for calcium. And this is supposed to go through a 6 French, but we have an Ansel sheath here, and the Ansel sheath has a slightly smaller ID than the Terumo destination, so I hope this goes through. That wire, let me take a better picture here. Does anybody have concern about the wire?
I think your wire approximately looks okay. There's a question. I wonder if there's a dissection plane proximal to your original occlusion, unless that's just wire streaming in your previous angio. Oops.
Yeah, this is going off into some other plane here.
One more back.
More back.
So as you figure that out, Lawrence, any concerns about atherectomy in the situation where you're fairly certain that you may have been subintimal for a period prior to going into the true lumen? Any concerns about perforations in that situation?
Yeah, so we've done a ton of atherectomy in CTOs, and we've had our share of complications doing it. But I don't think it's inherently risky as long as you. The key is to keep your wits about you. I mean, all you need to do is create a lumen. The question is, do you need to create the lumen as opposed to stent, or do you have to create the lumen as opposed to DCB? I think that's a harder question for me to answer. I think here, I'm pretty comfortable that as long as you aim towards where you think the lumen is, this is where this question of imaging becomes important, but as long as you aim towards the lumen, you probably can get away with a short amount of atherectomy to reconstitute
a little bit more
the specimen.
proximal.
I think we're good here.
Is there a dissection proximal though in that popliteal? Yeah, exactly. Right here.
So what you were saying is you stay away from that. You point your cutter away from that.
We like to see from P1 segment.
Okay. He's complaining of something. Patient's complaining of something. He may be cramping.
Yeah. Those cramps are overwhelming.
Yeah, it's a dorsiflex foot. Is it a cramp?
Cramping.
If he pulls his foot up, if somebody can push his foot up, it'll get better. Yeah.
So Rajesh, we're running out of time here.
Yeah.
Give us a summary of how you plan to move ahead with this case and give us an excellent result.
Sure. So I think we're almost there. I just need to be completely sure that we're in true lumen, and I'm pretty sure we are, because that'd be the worst thing to do is to do an atherectomy to the false lumen, push it up this way. No, like this. Yeah. That'll make it better. And so atherectomy here with a small vessel cutter, and then I think we'll have a pretty good result with that. We're not going to go for an optimal result, just to debulk it, create a good channel, and then use a DCB. Probably a 4.0 by 120. So that would be the goal here. There is a space at the end of the tibioperineal trunk where we can plant our balloon. So I think that should give us a good result. Better? Okay.
So very good, Rajesh. It's 6:02, it says over here. Thank you very much for a demonstration of a very challenging case of a CTO and some excellent wire work. And good luck for the rest of the case. Thank you very much.
Thank you very much.